Hello, everybody. My name is Marco Maggiorini. I am the chair of this session sponsored by Estor on the endotoxic shock and the role of advanced blood purification therapies. I have to give the apologies of Ricardo Ferrer, who is not with me for chairing this session, but because he has another commitment, he will give his talk, which is pre-registered. And then we will discuss together the different talk at the end. So just to remind you that you have a chat link where you can ask questions as well. I'll try to select the most interesting session in order to finish our session on time in 1 hour from now. So I would like not to lose more time than needed, and I would like to introduce Ricardo Ferrer Roca, who is from Barcelona, Spain. He is a well-known intensivist and infectiology specialist, and he will give us an interesting topic on complications of COVID-19 infection regarding endotoxic shock. With the idea that potentially this viral infection may lead to immunosuppression and danger life-threatening endotoxic shock. So, Ricardo, thank you for coming, and you can start with your talk.
Hello, everyone. My name is Ricardo Ferrer. I am the head of the ICU in Valdebrona University Hospital in Barcelona, Spain, and I'm going to talk about endotoxic shock and COVID-19, the dysregulated host response to infection. Those are my conflicts of interest. You can see in this slide the surge of COVID-19 infection in Europe, and you can see that during this second wave, we are assisting thousands of patients per day in Europe. The reason for that is that when SARS-CoV-2 is able to enter these epithelial cells in few hours, in this case, the photography was taken after 72 hours of the inoculation of the virus, there is a massive production of virons outside these epithelial cells. And this, in fact, causes an infection that can be asymptomatic, but the cases we are seeing in the hospital, in the ICU, are those cases with moderate or severe infection. And of course, many patients can recover, but some of them will die. And the reason for that is that the patients who recover or have mild infection, they have a protective immunity. They produce neutralizing anti-spike protein antibodies. They have a good also cytologic response to this infection. On the other side, the patients who die have an immune dysregulation with hypercytokinemia, coagulopathy, and organ dysfunction. And you can see here also again the burden of the disease in Europe and the increase in all-cause mortality that we had during the first wave in spring and what we had during the second wave during the autumn. So a lot of extra death because of the pandemics. So here in this cartoon, you can see the effects of the infection and how the immune system counteract this infection. In the right, you can see the healthy immune response with the production of neutralizing antibodies and how the macrophages are able to clean the virus. And at the same time, the immune cells also have an adequate and adaptive response to this infection. But in the left side, we have the patients that we see many times in the ICU with this regulated immune response that produce an increase in inflammation, the inability to control the virus, and in fact, a local and systemic inflammatory response. This is the effect of this infection and this dysregulated inflammation at the alveoli with the production of this edema and the activation, also the coagulation with formation of microthrombi in the capillaries close to these alveoli. we have seen that patients that are severely ill in the ICU, in fact, they have higher rate of viremia and higher inflammation. So the inflammatory response is high and unable to control the virus. And in fact, not only those patients with viremia are more sick, have higher inflammatory response, but at the same time, they have also lymphopenia and several degrees of immunosuppression that predispose the patient for nosocomial infections when they are in the ICU. In fact, the levels of cytokines are elevated, so these patients have hypercytokinemia, but if you compare the levels of cytokines in front of other types of RDS, the levels are lower and much more lower than patients with sepsis or patients with cytokine release syndrome that we see from time to time in our ICUs, meaning that the inflammatory response, it seems to be lower than sepsis or cytokine release syndrome. Usually, the common biomarkers of sepsis, like PCT, are not elevated, and when they are elevated, it's because the patient has a superinfection or because they have a very severe form of COVID-19 infection with an increase of 5-fold in mortality in patients with high levels of procalcitonin, for example. The involvement of the endothelium is very clear. Those patients with this infection has an involvement of endothelium, but if you look to the risk factors for severe forms of COVID-19 pneumonia, they are also the risk factors are patients who have chronic activation of the endothelium, like patients with diabetes, cardiovascular disease, aging, or obesity. So those patients that have a pre-activation of the endothelium are a higher risk of a sicker form of COVID-19 infection, and also patients with some polymorphisms in genes in chromosome 3 and chromosome 9 also are more prone to have these severe forms of COVID-19 pneumonia. So nowadays the treatment are for this infection it's a combination of different treatments that try to control the virus, like remdesivir, or passive antibodies, or treatments that try to control the inflammatory response, like the steroids, monoclonal antibodies against these mediators of the inflammation, anticoagulation, of course, because this is a prothrombotic disease, and also hemoperfusion, which is the topic for today. And also, of course, the patients need to receive support therapies if they have failing organs. And I have to say that this is a very important part of the treatment nowadays. So if we want to reduce the mortality by COVID-19, we have to have a prepared ICU bed with all this equipment and expert intensivists to treat this patient. I think by now is the best way to reduce mortality. Passive antibody therapy using convalescent plasma, so in vivo products or in vitro products like the monoclonal antibodies cocktails has been considered an alternative, but I think that there are not evidence by now that it works in severe patients. In fact, the last trials with convalescent plasma done in Argentina are showing neutral effect of this way of blocking the virus using this passive immunization with convalescent plasma, but also the in vitro produced monoclonal antibodies, like the ones from Regeneron, by now has not been tested in patients or approved in testings in patients who are hospitalized or patients that require oxygen. So those are alternatives for non-severe patients. As I said before, COVID-19 infection is a prothrombotic disease. You can see here the production of microthrombi in small pulmonary arterioles which is very frequent, and in fact 31% of the patients in the ICU have thrombotic complications. Respiratory complications are the most important ones, like mucus plugging, tracheal perforation in some cases, several forms of pneumothorax or pneumomediastinum related to this, this trauma, pulmonary embolism and thrombosis related to this procoagulant state, in some cases with pulmonary infarction, but bacterial pneumonia, in some cases necrotizing pneumonia with emphysema, are the most common complication. The reason for that is that we know from other viral pneumonia that the virus are able to prepare the lung for this superinfection. So the direct mucosal and epithelial damage done by the virus is able to enhance bacterial adherence, and at the other side, the host has this immune deregulation that both factors together make much more easy to develop bacterial superinfection. This is now for influenza, but now we know that these superinfections are also common in COVID-19. In influenza, co-infection is quite frequent at the moment of hospital or ICU admission. Close to 16% of the patients develop these bacterial co-infections. And bacterial co-infection is a risk factor for mortality. Number one in this case is strep pneumonia in the case of influenza. In the case of COVID, in patients with RDA requiring mechanical ventilation, the incidence of bacterial superinfection in the lung is quite frequent. Initial studies show 31% in China, 65% in Italy, and in fact, these meta-analyses show that initial co-infections is infrequent, 3.5, but superinfection during the ICU stay or the hospital stay is much more frequent, close to 15%. And a lot of patients receive empirical antibiotics and ICU admission, with a lot of variability, as you can see here in this slide, representing 32 hospitals in the US, going from less than 30% receiving empirical antibiotics to other centers that more than 80% of the patients receive empirical antibiotics. Also, these respiratory complications in forms of infection is the main reasons for ECMO support in some centers, and also this type of infection is the reason for mortality also in patients in support in ECMO. When we look to the epidemiology, you can see here that gram-negative bacilli are the most important microorganisms involved in this type of superinfection, with Pseudomonas, Klebsiella enterobacter, Serratia and Acinetobacter being the most important one. This study was done here also in Barcelona, in Clinic Hospital, showing that 25% of the patients develop ventilator-associated pneumonia, and again, Staph aureus, Pseudomonas, Stenotrophomonas are the main reasons for this type of infections. So how we can detect this infection? We can use the levels of PCT. I said at the beginning that PCT usually is low, but if we monitor levels of PCT, we can see an increase, but also hemodynamic instability is also a factor, together with leukocytosis, that can tell us that the patient has a bacterial superinfection. In our experience that will be presented during this Congress, during the first wave, we have 251 patients intubated and in mechanical ventilation, close to 100 developed BAP, and the most important microorganisms involved, again, were gram-negative bacilli with Pseudomonas and Klebsiella as number one. And important to say that 13% of the BAP episodes were necrotizing pneumonia, and multi-drug resistance microorganisms were involved very frequent. If we match our patients with pneumonia with non-pneumonia patients, you can see here that steroids are a risk factor for this bacterial superinfection, and also in this matching, mortality is increased in patients with this bacterial superinfection, also time to death is lower in patients with bacterial superinfection. This is a Spanish registry supported by the Spanish Society of Intensive Care, showing that the density of incidence is around close to 12 cases per 1,000 days of mechanical ventilation. And when we look in this registry, which are the main microorganisms involved, again, Pseudomonas aeruginosa is the most important one, 36% of the cases. Another important Spanish registry in which I am involved, and the results also will be presented during this Congress, the Ciberes-UCI COVID registry, we found that 35.6% of the patients have respiratory infection, but also bloodstream infection and urinary tract infections were very frequent in patients admitted in the ICU with COVID-19 infection. And again, in general terms, Pseudomonas, so gram-negative microorganisms, were the most important one involved in these infections. If we analyze endotoxin in the setting of COVID-19 patients, you can see here that most of the patients admitted in the hospital, in fact, has gastrointestinal symptoms and also release viral RNA in the feces. If we look at those patients during the complete hospitalization, 81% in fact developed gastrointestinal symptoms. Here you have the distribution of endotoxin activity during the different days of the evolution of COVID-19 pneumonia, and you can see that the patients with levels above the cutoff of 0.6 are very frequent during this hospital stay in patients with COVID-19 pneumonia. In vitro data show also that there is a synergistic effect of LPS together with the spike protein of SARS-CoV-2. So where both act together, they boost the inflammatory response in vitro studies, but also in this in vivo model of inflammation. You can see that the inflammation is maximized when the animals receive the combination of LPS together with the SARS-CoV-2 spike protein. So it seems that for different reasons, endotoxin are also playing an important role in the pathophysiology of COVID-19 pneumonia, especially in those patients that present bacterial superinfection. So I think hemoperfusion should be considered as part of the treatment of the immunomodulation in the most severe patients in the ICU. In fact, in our protocol here in Vall-d'Hebron, we use hemoperfusion in patients with IL-6 levels above 1,000, D-dimer levels above 1,500, ferritin levels above 500. If they are in RDS, not responding at prone position, those patients are ideal for us for indication of hemoperfusion. And in fact, the recommendation from the group of Claudio Ronco is that some of these patients are going to have high levels of endotoxin, and then we should, and the reason for that, of course, is because this gut involvement in the pathophysiology of COVID-19 infection, but also because this gram-negative superinfection that are able to instabilize the patient. And also this is a very interesting target for any system like PMX for removing endotoxin, as this group of investigators promote. So as conclusions, I have to say that COVID-19 pneumonia is a devastating condition. It's not only RDS, there are other organs involved in the pathophysiology. We didn't discuss today about AKI, but also around 6 to 10% of the patients have also acute kidney injury. Bacterial co-infection is uncommon, but bacterial superinfection is frequent, especially in the lungs. But bacteremia and urinary tract infection are also very common. Gram-negative bacteria are the most important microorganisms involved in these infections. And I have concern about the liberal use of some medications like IL-6 monoclonal antibodies or steroids at high dose or anticoagulation, because it can promote this type of bacterial superinfection. COVID-19 pneumonia is an anti-inflammatory state. We have to try to go in both ways, try to control the virus, but at the same time to control the inflammatory response of the host. And in the setting of a patient with COVID-19 pneumonia and increase in endotoxin activity, discussing about hemoperfusion with PMX is an interesting option that my colleagues will discuss in the next talks. Thank you for your attention.
Thanks, Estor, for inviting me. My talk will be on endotoxic shock, role of polymyxin B, hemoperfusion. So, is the cytokine storm relevant in septic shock? As we know, everything starts with an interaction between host and pathogen. And the pattern recognition receptor recognizes the elicit response against pathogenic factors, for example, PAMPs. And from one side, we have pro-inflammatory response. So we have leukocyte complement coagulation cascade activation. From the other side, we have anti-inflammatory response. So we have an impairment of immune cell function. We have apoptosis of T, B, and dendritic cells, and we have an increase of regulatory T cells. So in this case, inflammation is a necessary evil. So we have an insult that triggers and sensors, and one of our PAMPs, in this case, the LPS, that is one of the most potent immune activators that gain prominence. And as immediate results, we have cytokine storm. So if it is true that peak concentration hypothesis exists, and if it is true that the peak of cytokines can be cut from blood purification therapies, for example, high volume, high filtration, or high cutoff membrane in CVV HD modalities, in the same time we can go straight on endotoxin and we can perform hemoperfusion. So endotoxic shock exists, and just as we can see in this editorial in 1964, was defined as a release of toxin from gram-negative bacteria, but was still a therapeutic dilemma because at that time no technique existed for removal or inactivate the causative agent once it enters in the circulation. So now we are in 2020, and we can perform immunomodulation through cytokine removal, so we can go straight on immunodysregulation, but in the same time we can go on infection, so close to SUS control, we can perform endotoxin removal. We can do that through adsorption, that is an extracorporeal process in which molecules dissolve in plasma or blood bind to the membrane structure or to other adsorbing substances. So when we use a cartridge for adsorption, we have to evaluate not only the selectivity, but also the device adsorption capability. That is the total quantity of a specific molecule that the device is able to adsorb. We have a lot of devices designed for endotoxin removal and for cytokines removal in sepsis, and we have to perform the endotoxin activity assay, that is a chemiluminescent bioassay based on the oxidative burst reaction of activated neutrophils to complement coated LPS EGM immune complexes. And if we consider the dose response curve for endotoxin, an EA value of 0.9 is equal to 4 nanogram per milliliter. So if we consider an adult patient with endotoxin activity of 0.9, blood volume of 5 liters, the endotoxin burden is around 20. But if we consider interstitial space, the volume is higher, the endotoxin burden is 52 microgram. And if we consider a 0.9 value over 0.9, we have a not determinable, and the endotoxin concentration is 50 microgram. So go back on a device, and the device absorption capacity of thoramycin is 64 microgram, and so we are able to fight the endotoxin burden over 0.9, so over 52 microgram, compared to the other device, LPS adsorber and Oxiris, so is superior to thoramycin in this case. Polymyxin B immobilized cartridge was developed to combine the potent endotoxin neutralized capabilities of polymyxin B with extracorporeal hemoperfusion, and we are able to perform an interruption of inflammatory cascade, a decrease of excessive systemic host inflammatory response to infection, but we can obtain a recovery from immunoparalysis and sepsis. We have a lot of randomized control trial. We have 2 data registries, EUPHAS-2, phase 1 and phase 2. And the first randomized control trial was Italian, was the EUPHAS study, 10 tertiary Italian ICU, 64 patients. The absolute risk of death at 28 days improved significantly from 53% in the conventional therapy group to 32% in the polymyxin HP treated group. But the trial was not blinded, and the population was septic shock patient with an intra-abdominal source, and the endotoxin activity assay was not measured. Abdomix is a French randomized control trial, and 240 patients were septic shocked due to peritonitis and were randomized to standard care versus standard care plus polymyxin B, polymyxin HP. 28 days mortality was higher in polymyxin B group versus control, but was not significant. They had a lot of technical issues, and the observed composite mortality was less than the estimate, including in the sample size calculation, thus decreasing the power of the study to detect the difference. EUPHRATES was a multi-center blind sham randomized control trial conducting 50 ICU in the United States and Canada, 450 patients, and there were septic shock and confirmed endotoxemia using endotoxin activity assay greater than 0.6. Non-different was found 28-day all-cause mortality, but the trial showed that in some patients with septic shock, the burden of endotoxin activity was extreme, over 0.9. So the protocol was modified, and an interim analysis suggested a lack of effect in the patient with MODS of 9 or less, and those patients were excluded. In a post-hoc analysis, authors evaluated the impact of polymyxin use in patients with septic shock and endotoxin activity measured between 0.6 and 0.89, and the mortality at 28 days was lower in polymyxin HP group and was significant. So we had a lot of trouble in this study because the endotoxin activity was not always measured, and concerning the timing of starting the polymyxin B HP, sometimes was after 24 hours, sometimes after 48 hours, sometimes after 12 hours. And we have some doubt concerning the mortality, but what we saw was the significant survival benefit, and we have more than 300 peer-reviewed articles on PubMed. So I was thinking that in the last year that the timing was important. For this reason, in our center, we designed this flow chart. So when we have in our emergency department a patient with septic shock, we perform in 4 hours the endotoxin activity assay. And if it is over 0.6 or less than 0.6 with positive blood culture, in a 6 hour, we confirm endotoxin shock, and we start with the polymyxin B hemoperfusion. After 24 hours, we perform the second treatment. We monitor the response with biomarkers, SOFA score, and when there is a kidney failure, we perform sequential therapy. Sequential therapy, extracorporeal therapy in sepsis is something that is not still validated in literature, but is a novel approach to the septic patient with multi-organ damage in order to provide the critical patient with the most suitable therapy moment by moment. And it requires an expert multidisciplinary team able to perform appropriate and dynamic patient's prescription based on close monitoring on the patient's clinical condition at the bedside. So important in this time a registry. EUFAS-2 is an effective example showing that a multi-center registry might be useful in categorizing the clinical use of a specific extracorporeal blood purification therapy in the real clinical context and identifying clusters of patients in which the treatment may be more effective. And from this registry, we took 20 patients in a time from May 2019 to May 2020. So in this cohort was 70% males. We had in 50% no surgery before admission. 40% of patients had community-acquired pneumonia, and those patients had a SAPS-2 score of 71.5. What we saw was a decrease of vasoactive entropy score from T0 to T120, and also SOFA also lactates, and there was a decrease in endotoxin activity from T0 to T72. The ICU mortality was 30%, and just one more patient died out of ICU. What about COVID-19? Is the cytokine storm relevant in COVID-19? Probably no, because there are no current data do not support its use, and the linkage of a cytokine storm to COVID-19 may be nothing more than a tempest in a teapot. As we can see in this study, critical ill patients with COVID-19 with ARDS had the circulating cytokine levels that were lower compared with patients with a bacterial sepsis, similar to other critical ill patients. The findings of this preliminary analysis suggest COVID-19 may not be characterized by cytokine storm. Probably there is an association with deep and sustained multiphase cellular immunosuppression. So what about endotoxin COVID-19 patients? Some patients come with respiratory symptoms without digestive symptoms, but some with the digestive and respiratory symptoms. So symptoms can be at admission, and the viral RNA detection was in feces. And sometimes during hospitalization, so GE trap may be the potential transmission route and target organ of SARS-CoV-2. SARS-CoV-2 spike protein binds to bacterial lipopolysaccharide and boosts pro-inflammatory activity. So we can have direct infection of the gut mucosa, decreased antibacterial defenses, increased mucosal permeability, bacterial translocation, and systemic leak of endotoxin. And so in this kind of patient, we can have superimposed infection. So if we suspect or confirm gram-negative bacterial infection, we have to measure endotoxin activity assay, endotoxic activity assay. And we have to use hemoperfusion if there is a result between 0.6 and 0.9 with a cartridge able to perform adsorption, so Polymyxin B hemoperfusion. As suggested by this panel of experts, should be used for 2 subsequent days. And if cytokine release syndrome is present, this treatment should be followed by methods for cytokine desorption. And if organ support is required, CRRT should be implemented in conjunction afterward. So endotoxin and SARS-CoV-2 particles potentially can contribute to the development of multi-organ failure. And we need the registry. So from EUFAS, we took 5 patients that we treat from March 2020 and May 2020. And we used this intervention flowchart as I showed before. We had, those patients had the SAPS-2 around of 68. And at 28 days, 4 patients were alive, and out of ICU, 1 more patient died. So 3 alive and 2 died. So what we had was an improvement of the vasoactive inotropy score and decrease, and the SOFA and the decrease in lactate, and we have a decrease of endotoxin activity assay from T0 to T72. So conclusion, in a comprehensive approach to the endotoxin shock treatment, the evaluation of kidney function, vasopressor requirements, endotoxemia together with source control and antibiotic therapy based on the time from sepsis diagnosis may have a role to personalize the treatment for each specific patient. The dynamic monitoring and prescription could further refine the treatment personalization, adequately responding to the criteria of precision medicine. Thus, not only a specific treatment could be provided for every single patient, but even a more specific treatment shall be provided for every moment that patient has a particular need during his ICU stay. So, Polymyxin B hemoperfusion could be a safe blood purification therapy to be considered for management of unresponsive endotoxic shock, resulting with a clinical benefit for patient. And thanks for listening to me.
Thank you for inviting me to this symposium. My talk today will be on sepsis-induced acute kidney injury, AKI, from pathophysiology to the role of dialysis membrane. This is the agenda of my presentation, starting from the epidemiology, experimental, and clinical evidences of sepsis-associated AKI with a small window of COVID-19. And the second part of my talk will be on potential clinical intervention, obviously focusing on dialysis membrane and absorption devices. We start from epidemiology, and we know from the sepsis-free international consensus that sepsis is now defined as a life-threatening organ dysfunction and a concomitant dysregulated host response. And this host response is caused by the presence in the bloodstream of these different mediators able to interfere with the function of different organs, obviously including the kidney. From an epidemiological point of view, as suggested by the AKI Advisory Board of the American Society of Nephrology, you can see here that about 20% of hospital admission develop AKI, and in this 20%, 1-2% develop AKI requiring dialysis. So this population is characterized by a high mortality rate, about 40 to 60%, in a context, in a clinical scenario of multiple organ failure due to sepsis, septic shock. The other important point for nephrologist's point of view is the potential progression from AKI to chronic kidney disease, with an important increase for the healthcare cost. The same situation is reported in Italy. This is our hospital at the University of Piemonte Orientale in Novara. Following the project of the Italian Society of Nephrology, we can see that AKI in hospitalized patients is about 18%, divided in AKI stage 1, 10%, 4% stage 2, 2.7% stage 3. And you can see the increase of mortality from no AKI, 3%, AKI stage 1, 9, and AKI stage 2, 3, 17, 18% of mortality. And again, the major cause of AKI in this population is sepsis or septic shock. This is because in comparison to non-septic associated AKI, sepsis-associated AKI is characterized by an increase in mortality and increased progression toward chronic kidney disease. So we have a complete different phenotype of AKI patients in presence of sepsis. From a pathogenic point of view, the predominant paradigm, the dogma, was that AKI associated with sepsis was due to vasoconstriction, to ischemia. This is not completely true, but experimental data from histology data, and in particular, looking at the experimental setting in sheep from the Rinaldo Bellomo group in Australia, you can see here that after an infusion of E. coli bolus, you have obviously AKI, an increase of serum creatinine, but the renal blood flow is not decreased, it's normal or even increases. So there is a clear dissociation between renal blood flow and renal function, and AKI in the course of sepsis may occur in presence or a normal or even increased renal blood flow. This may be due to a different distribution of the microcirculation, but take us to consider some other hypotheses that are more toxic or immunological in nature. We know that pathogen, PAMs, and damage or danger-associated molecular patterns, PAMs and DAMs, may have a key role in the determination of organ injury, including the kidney, including acute kidney injury. And we know that endotoxin may have a key role in this. Basically, as shown by John Kellum and others in this cartoon, PAMs and DAMs can be freely filtered by glomeruli, reaching the tubular lumen and causing tubular cell damage from this part. But PAMs and DAMs can also alter endothelial cells' function, generating microthrombosis through the lack of nutrient and oxygen to tubular epithelial cells, and again, tubular epithelial cell damage. So we have two different targets: endothelial cells, inflamed and microthrombosis, and tubular epithelial cells that undergo dysfunction and the bioenergetic derangement. When we consider endotoxins, so LPS can reach the kidney, activating toll-like receptor 4 and generating oxidative stress and local inflammation. Obviously, can also act on systemic TLR4, inducing the release of different inflammatory mediators, cytokines in particular. And these cytokines can reach different organs, in particular TNF-alpha and Fas ligand. We know that these cytokines are increased during sepsis, can reach the TNF receptor and Fas receptor present on different types of cells, including apoptosis. So apoptotic cell death is a common denominator of organ damage during sepsis, and the activation of these pathways can lead to acute kidney injury, but also to acute injury of the liver, of the lung, of the heart, and of T cells, causing the immunoparalysis, immune dysfunction that is typical of the high mortality in septic patients. This is in accordance with what we have demonstrated some years ago at the University of Torino. This is a simple experiment, taking the plasma of septic patients and incubating with the plasma of septic patients human tubular epithelial cells. So without any kind of hypoxia or hypoperfusion, you can see that this plasma induces apoptotic cell death. This is the DNA fragmentation of tubular cells, the activation of caspases and Fas pathway. And this apoptotic effect was concomitant to the presence of a low molecular weight proteinuria in septic patients and with other signs of tubular injury, such as fractional extraction of sodium and potassium. So basically, the plasma of septic patients contains some pro-apoptotic and pro-inflammatory factors for tubular epithelial cells. To sum up, we have some cytokines, chemokines, and also extracellular vesicles can reach endothelial cells and tubular epithelial cells, inducing mitochondrial dysfunction, loss of polarity, inflammation, so increasing leukocyte adhesion, and triggering necroapoptosis. And another important cascade is the complement pathway that is known to be activated in sepsis-associated AKI. As you can see in this experimental model in baboons, the infusion again of E. coli induce AKI, the increase of serum creatinine, and simultaneously the activation of the complement cascade. You can see here with the immunofluorescence for the membrane attack complex, the C5b9 protein at the level of the kidney in this baboon. So sepsis is associated also with complement activation, and we know that complement can induce several injurious mechanisms on renal resident cells, on tubular cells. Complement activation induces epithelial to mesenchymal transition and senescence with a decreased expression of clotho. On endothelial cells, complement activation induces endothelial to mesenchymal transition, so taking together fibrosis, and again also the activation of the innate adaptive immune system. And these same mechanisms are shared in SARS-CoV-2 infected patients who develop AKI, and this is an AKI in SARS-CoV-2 in COVID-19 patients has been reported about 20-25%, also requiring a renal replacement therapy. And we know that from these elegant studies reported in New England Journal of Medicine that SARS-CoV-2 can enter not only the lung cells, but also the kidney cells, can infect podocytes, can infect tubular cells, can infect endothelial cells, and mRNA for the virus is detected in all these cell types. if we consider the endothelial cells, so basically SARS-CoV-2 can bind to ACE2 receptor, enter the endothelial cells, inducing inflammation, but also triggering a procoagulant state, hyperfibrinolysis, and inducing complement activation. So basically, COVID-19 is a thromboinflammatory disease, as suggested for sepsis, with a dysregulation of the microcirculation due to microthrombosis. Again, we can sum up with a cartoon of COVID-19 in which the virus induced local and systemic inflammation, the activation of the coagulation and complement cascade. But again, as reported in sepsis, in a sort of mirror image, also T-cell exhaustion and tolerance that are all associated with a worse outcome. And to sum up in this acute disease quality initiative work group, we reported here which are the main mechanisms for AKI during COVID-19 with direct viral effects on the kidney, so endothelial damage, coagulopathy, complement activation and inflammation, and some other indirect effects such as mechanical ventilation, fluid management, nephrotoxins, organ crosstalk, sepsis due to superinfection with bacteria. And so we know that we are the so-defined cytokine storm in sepsis and also in COVID-19, as I just showed you. But this storm is very complex because it's formed again by the complement and coagulation system activation from the release of different types of cells, blood and lymphatic cells, vascular and tissue cells of different mediators, inflammatory mediators such as cytokines and chemokines. And obviously, this plethora of circulating mediator in bloodstream may be a target for extracorporeal blood purification technique. So we have different lessons from a randomized controlled trial on blood purification in sepsis-associated AKI. A first important point, we observed the key mechanism by which LPS endotoxin can damage the kidney. So LPS is a key target to be blocked. And we know from this webinar that Polymyxin B hemoperfusion can block LPS through the binding, through the ionic forces that are weaker or hydrophobic forces that are stronger during Polymyxin B hemoperfusion. We know there are several clinical trials reporting some beneficial effect on outcome, and in particular on organ function, including the kidney, using Polymyxin B hemoperfusion, from the starting UFAS to the registry UFAS2 to the more recent Euphrates. But what I want to underline, this is one of an old study at the University of Torino in which we compare Polymyxin B hemoperfusion with conventional therapy. Again, in vitro, in lab, with our assay of incubation of human tumor epithelial cells with the plasma of patients, you can see that after Polymyxin B hemoperfusion, there is a decreased pro-apoptotic activity of this plasma. So Polymyxin B hemoperfusion can inactivate circulating pro-apoptotic factors. And this is also observed in patients with a significant decrease of SOFA score, of the Reifler criteria for AKI, and to the decrease of LPS and of cytokines, such as TNF-alpha. But we have to remember, taking this in mind, that when you have AKI, AKI is an inflammatory disease. So we have a further increase of inflammatory mediators in the bloodstream. You can imagine that after AKI, we have a 1,000-fold increase of IL-6, for instance, in the bloodstream of our patient. And this inflammatory reaction can lead to the alteration, to a further dysfunction of other organs, including the kidney. This has been observed in COVID-19 patients. So we come back to the so-called peak concentration hypothesis proposed by Claudio Ronco some years ago. So can we interact with these inflammatory cytokines in the bloodstream using blood purification techniques? The answer is yes. Obviously, we can choose some specific devices or better membranes with characteristic of absorption. I think that this 3D hemodialysis adding absorption to conventional diffusion and conventional may be a good idea. And this is what has been already demonstrated by the Ghent group some years ago and published on the Journal American Society of Nephrology, in which they observed calculating the mass absorption during continuous venous hemofiltration, that the majority of these cytokines are removed not by convention, but by absorption. But obviously, you have to use the right membrane with absorptive capacity. One of these membranes are PMMA, polymethylmethacrylate. You can see here the effective working thickness of PMMA that is completely different by standard polysulfone you use it in CWH. And from the chronic hemodialysis, this is a proteomic analysis, clearly showed that PMMA is able to increase the clearance of different uremic toxins of different molecular weights. So we can increase the removal of this uremic toxin inflammatory mediators using this absorptive membrane, the PMMA. And we know from the literature that PMMA has been associated with cytokine absorption in sepsis-associated AKI, causing the decrease of TNF-alpha, IL-6, IL-10, and other inflammatory mediators. And so I go to the end of this presentation showing some preliminary results that we obtained in an experimental smile model of sepsis-associated AKI using hemofiltration with polymethylmethacrylate membrane. The PI of this investigator is Foggia, together with the other groups in Bari, in Vicenza, and myself in Novara. It's a very simple experiment in which the infusion of LPS and the start after 3 hours of the treatment, hemofiltration with PMMA versus hemofiltration with polysulfone for 7 hours, and then the sacrifice after 24 hours. What we observed is an amelioration of the hypotension, an increase of urine output, and a better serum creatinine levels. So we have a functional protection on the kidney that we observed also at the histological level. As you can see here, LPS induced the infiltration of inflammatory cells and tubular cell damage not observed with PMMA-CWH, and also LPS induced glomerular microthrombi and the presence of an early fibrosis in the tubular interstitial spaces and in the capillaries that is not observed, but is significantly decreased in PMMA-CWH. Since this increase of fibrosis may be related to complement activation, we decided to investigate the complement system during PMMA hemophilia in septic AKI. And interesting, we observed a significant decrease of both the classical and alternative pathway on the complement during using PMMA. This is also seen in histology. You can see here LPS induced the expression of pentacin-3, in particular of the membrane attack complex C5b9 in the kidney. And you can see here that PMMA-CWH significantly decreased a complement activation, and this is not observed using polysulfone during CWH. And the comparison, the whole genome gene expression profile of SMIME PBMC confirmed this data. So you can see here the complete the differences between the expression the gene expression profile of LPS versus PMMA, and in particular LPS induced the overexpression of granzyme B and complement factor B that is completely inhibited from PMMA by PMMA membrane. So again, PMMA can block complement activation and the release of other inflammatory mediators able to induce kidney injury. To sum up and come to the end of the presentation, the PMMA hemofiltration in septic AKI can improve urine output and tissue hypoperfusion, so we can have a decrease of renal damage, a decrease of complement activation of early fibrosis, and this is also observed with the decrease of classic and alternative complement pathway and to the decrease of other inflammatory mediators such as CD40 ligand and CD40. So we have a sort of protective effect of this membrane of sepsis-associated AKI. So this membrane can get rid of different mediators that are able to interact with renal resident cells inducing AKI. And probably this membrane is also able to restore immune homeostasis. If you look at the data on the complement activation, we know that during sepsis, we can have a maladaptive response in terms of both immune activation or suppression, and the extracorporeal blood purification technique can restore immune homeostasis. This takes us to the final slide with the so-called sequential therapy. If you think at the initial slide on the bloodstream with these different mediators, today we can act with polymyxin B hemoperfusion to block LPS, but we can also act with the PMMA membrane to block the complement activation of the cytokines in this so-called sequential therapy. Using sequential therapy can lead us to a sort of personalized therapy to block the mechanism, the pathogenic mechanism of sepsis-associated AKI, so we can treat the right patients with the right therapy at the right time. So thank you to all the contributors at the University of Bari, Foggia, and the International Renal Research Institute of Vicenza, and obviously on my team at the University of Piemonte Orientale in Novara. And thanks again for the invitation.
Thank you very much for your interesting talks, all three of you. And we have just a few minutes for some kind of discussion. Maybe I have a question first for Silvia. And the question is, how do we detect the patient that are in need for a hemoperfusion treatment? So when is bacterial infection overcoming? I think this is quite a difficult, task.
Yeah, concerning my clinical experience, when a patient comes in emergency department, for example, they, we did a protocol, so they have a time to perform endotoxin activity assay. So the patient is septic shock, and they perform blood culture, they perform the endotoxin activity assay, and when we have just 4-6 time, because we have such a golden hour to have the result, to start if we have a positive endotoxin activity assay and high suspicion of gram-negative, septic shock origin, and we start hemoperfusion with polymyxin B. Later, we decide if they need renal support to perform a sequential therapy with renal replacement therapy.
Thank you for your answer. But this is at the initial presentation of the patient. Usually what we know and what Riccardo told us, that initially there is a little co-infection of the COVID patient, and then co-infection appears during the course of the disease. And he mentioned PCT as a potential marker for infection. What do you think about that?
Yeah, that's right, because this is a setting is the ICU, so we have a COVID-19 patient in ICU, for example, and so procalcitonin will be positive. We have lower white cells, and we have patient with a high temperature and really low blood pressure. So we start endotoxin activity assay, and we want to confirm the endotoxic shock. Okay. This is my experience.
So you're measuring regularly endotoxin activity?
Yeah, I perform it, yeah.
Okay. Now, questions to Vincenzo. You presented kind of interesting results about PMMA membrane and suggest at the end of your talk the combination of the polymyxin membrane and the PMMA. You justify this by binding and activation of LPS, induced activation of the complement. Practically, how you do this? You suspect sepsis and then you start immediately, or you measure as well EAA and then you choose whether you use the one or the other treatment?
Yeah, thanks for the question. It's not so simple to measure all the other things, including cytokines or complement activation in the real life or the practical clinic, obviously. I think what we do is the same thing that Silvia described, so to test endotoxin activity assay, and so to know which are the endotoxin levels in our patients. For the other things, obviously, we are at the experimental phase. So we need probably some biomarkers to combine the activation of the complement cascade and of other types of cytokines. And from a nephrological point of view, also probably to combine endotoxin activity with biomarkers of tubular injury to early identify which patients are going toward toward acute kidney injury. I think that one good point may be the point raised from the Riccardo speech on the endothelial dysfunction, also for to shift from the sepsis to COVID-19 patients. We know that we have some chronic dysfunction of these endothelial cells with chronic comorbidities such as diabetes, obesity, and chronic kidney disease. And obviously, you can have a sort of other priming effect on endothelial cells, or better to have further acute endothelial injury. So probably also having some endothelial biomarkers, and we know from experimental models of sepsis that we can combine probably these types of endothelial and kidney biomarkers with cytokines and endotoxin. I think that it's not so easy to identify patients. And this is one goal for us, to identify the right patients to treat probably at the right moment.
Okay, so thank you very much again to both of you. Unfortunately, our time is over, and I wish you a nice Congress if you have the opportunity to go and look to some of the talk. I would like to thank at the end again Estor for giving us the opportunity to discuss this issue in the context of the COVID. I think it is really important to realize that COVID patient may undergo sepsis as well, and that hemoperfusion may be, as Riccardo said, an additional option how to treat and save life in our patient population. So have a good time. Thank you very much, and bye-bye.